Cameras are locked and loaded. How do I look? Happy?
Jimmy, all set? All right, everybody, welcome to the first panel, Intervention by Innovation. The whole purpose of today's panel is to talk about innovation in the Ontario Canadian healthcare system for healthcare technologies and the adoption and a lot of the barriers to those adoptions too. So I'd like to welcome the moderator for today, Dr. Agostino Mena. Thank you very much. I'm just going to quickly present our panelists and then we'll get into the questions, okay? So this is Dr. Bob Bell to my left. Dr. Bell was appointed Deputy Prime Minister. Deputy Prime Minister.
Wow.
One day. Deputy Minister of Health and Long-Term Care, effective June 2nd, 2014. Prior to his role, he served as President and Chief Executive Officer of University Health Network for 9 years. With a deep understanding of the healthcare landscape and a passion for driving innovation, Dr. Bell continues to make invaluable contributions to the health and well-being of Ontarians. Thank you for this. Thank you. Elizabeth Keller. Actually, this is not a north.
That's okay.
It's not according to
We tried to match it.
Oh, Elizabeth Keller. So Elizabeth is the top executive and digital health strategist in Canada. She is recognized internationally, currently leading healthcare business development nationally at AWS. Named one of the top 10 women in digital health in Canada, she excels at collaborating across sectors to solve complex challenges and modernize healthcare infrastructure. Currently, leading at Amazon Web Services, Elizabeth drives innovation and adoption of new technologies to enhance healthcare services. Luca Lamai. Luca is the co-founder and CEO of Docera Health. A company focused on reducing healthcare professional burnout and improving patient care with AI technology. He's also a community partner with Microsoft, hosts Tech Odyssey podcast, and has won awards such as Best AI Startup in North America and Young Entrepreneur of the Year in Canada 2023. His leadership has driven Docera Health's rapid growth, serving numerous clinics and healthcare institutions. And finally, Justin Sandin. Justin is a health system leader, passionate about transforming healthcare delivery and patient experience through technology, data, and innovation. Justin is currently Director of Digital Transformation and Analytics at Niagara Health and has previously held various leadership roles at other leading Ontario hospitals and Ontario Health. Justin serves on the board of directors for the HIMSS Eastern Canada chapter. Justin's experience has provided him a comprehensive view of Ontario's health system challenges as well as deep understanding of the opportunities that exist in the digital health ecosystem. Welcome everybody to our first panel session. I'd like to start, the first question is directed towards Dr. Bell. How has the adoption of healthcare technology evolved in Ontario and Canada more broadly over the past decade?
Terrific. Well, thanks for that. And thanks for the invitation to be here. Having worked recently at Niagara Health a little bit, providing advice, I know how fortunate you all are to be served by such an excellent healthcare organization as Justin works at. Innovation and impact on healthcare, it's often looked at as being something that's in the future. So I wanted to share with you 5 examples of how innovation is making a huge impact on healthcare delivery today. Starting off with one story that you hear about all the time, which is the fact that artificial intelligence is going to solve every problem that we have. NVIDIA is the most valuable company in the world. That's one story. The second story that you heard about in introductory remarks is that every country has a health human resource crisis happening, especially in the area of primary care. You've heard about primary care docs who are leaving practice because they're burned out because they have to work 2 days a week simply filling in their charts and doing all the paperwork, doing all the background work that's not seeing the patients. They are dissatisfied with their practice because of that. And of course, they aren't looking after patients. They aren't responding to patients' concerns when they're doing that. So how do these two things come together and how's it impacting on care in Ontario right now? And the answer is artificial intelligence can have a major impact on allowing physicians to do more clinical care. What they love to do, what they're paid to do, what they want to do, and take care of some of that paperwork in the background. Simply by listening to the ambient noise of the discussion that's going on between doctor and patient in the room, hearing the doctor say that when he examines the right ear, there's redness and it looks like there's an ear infection there, saying that we want to order antibiotic for the patient that is going to be delivered to this pharmacy. By simply saying all those things as a doctor talks to you normally, this can be recorded, this can be transcribed, this can appear as a structured clinical note in the chart within seconds of the patient leaving the room, rather than the doctor sitting there typing for 5 minutes after the patient leaves, or even worse, taking the chart home with them and dictating when they get home. Now, is this kind of magicware that may be apparent 3 or 4? No, this is being used in Ontario today. The government, along with Ontario MD, has started the Ontario Medical Association and started a pilot project. Everything suggests that that pilot project is only limited by the fact that 1,000 people are knocking on the door and wanting to sign up. So there's a great example of how we can liberate probably about 30 to 40% of the primary care physician's time and allow them to treat more patients immediately. There's one example of what's happening today. Another example is you've all heard of wait lists, and especially, God forbid, wait lists for cancer care. The most frightening words in the English language are, I'm afraid you have cancer. I'm a cancer surgeon by background, know that. But the second most frightening words are, and we're not sure when we can start your therapy, right? And too many people are hearing that today. One of the treatments that has a particularly long waiting list is radiation therapy, where you get treated by radiant energy coming from an X-ray machine that kills cancer cells. It takes a while to plan that treatment. And up until about 3 years ago, the typical time for planning breast cancer radiation treatment for head and neck cancer, for lung cancer treatment, was about 3 days. So after you got all the screening tests done, the MRIs of your tumor, etc., it took 3 days to plan your treatment. And again, artificial intelligence can actually look at the digital images that have been gathered to demonstrate where your cancer is and for the doctor to say, here's where we want to treat that. And at Princess Margaret Hospital in Toronto, where I used to work and live is what my wife told me, not just spend time there, but live there. In that hospital, software has been developed that uses artificial intelligence to reduce the planning time for radiation therapy from 3 days to half an hour. So you get your staging, your screening finished now, and you start treatment the next day. There's a second example of how good it is. The third story you hear about all the time is that we have an aging population, right? And that people who are moving into their 70s and 80s are liable to have chronic disease. You've heard about our hospitals, Niagara Health System, all hospitals in Ontario, jammed with people who are waiting to get better, waiting to go home. We don't have enough hospital beds. This is a crisis. The waiting times in emergency departments relate to people not being able to leave yet. So keeping people out of Ontario hospitals is a major goal. And those chronic diseases that bring them there can be, again, managed by artificial intelligence. And that's happening today at my old hospital, the University Health Network, the Toronto General Hospital, the Piedmont Cardiac Center. They have adopted a treatment called Medley. Medley is a treatment that gives people blood pressure cuffs, oxygen monitors, and a way of reporting their symptoms online. So today I'm feeling pretty good. Tomorrow I may be a little more short of breath. The next day I may have a little bit of chest pain. All this gets reported along with how much oxygen is in my blood, what my blood pressure is, and a variety of other kinds of physiologic parameters. Tests that get recorded and sent to a big data set at the hospital. Now, you can't have a cardiologist sitting there waiting to look at this information. You can't even afford to have a nurse sitting there feeding through all this information. Can you afford to have artificial intelligence reading it and saying, beep, beep, here's a problem? All these people who've reported today have been fine. Those 10 were good. The 11th person, we need to talk to them. That approach, not to seeing people back in clinic every 3 months, but to look at them immediately based on the symptoms they have at home, that has reduced emergency department visits and has reduced hospitalizations for patients who have chronic heart disease at the Toronto General Hospital, one of the biggest providers of heart care in the country, by 30%. So keeping people healthy, keeping them out of hospital is something that's happening today with innovation that's been developed in this province. And I know Dan wants to keep it down, me to list only for 5 minutes, so I'm going to finish up by something that's happening here in the Niagara region. Because my goodness gracious, is innovation going to live here? You know it. And I've talked about artificial intelligence, I've talked about technology that is futuristic, requires a lot of money for investment. But one of the biggest problems that we have in healthcare as people age, as we deal with the aging population, is that as people age, they tend to fall. And falling is devastating. Somebody who's independent in their own home falls, fractures their hip, and suddenly the only answer is they have to become totally dependent on institutional care. And there are some very smart people that looked at this relatively straightforward problem and said, hey, perhaps we can solve this. And Dan and his company called Bicep has developed a device. What's it called, Dan?
The ARM device.
The ARM device that allows not only people to be more stable in their own homes when they're starting to get a little unbalanced and a little difficulty maintaining an upright position. And if they're starting to move into a wheelchair, it allows them, because one of the most dangerous things is standing from a wheelchair. The wheelchair scoots back and suddenly the patient's lying on the floor. Dan's device, which is going on the market after about 2 years of development now, will be produced here in the Niagara region, which already has pre-orders from across Ontario long-term care and Ontario hospitals. And I think it's going to be a lifesaver for a bunch of people who'd otherwise lose their independence through a fall. So innovation is crucial for the future of healthcare. Innovation is happening today. It's happening on University Avenue in Toronto, those examples I mentioned to you, and it's happening here in the Innovation Center at Niagara. So thanks for the opportunity, Dan, for the invitation, and look forward to your questions.
Check later. This question is for Justin, and it has to do with patient outcomes. How has healthcare technology improved patient outcomes in Ontario and more broadly Canada?
Thanks for the question. Yeah, and then certainly thanks for the invite to be here as well. I think when you think about patient outcomes, it's a pretty broad topic, and no question there is longstanding and rich evidence that suggests technology is highly correlated, if not causative, to leading to better health outcomes, better patient outcomes. That could be in the form of better patient experience. So think about online appointment booking tools, virtual care tools, a lot of what kind of was catalyzed through those 3 years of what we call the pandemic, but also health outcomes as well too. So people preferring to, as Dr. Bell was describing, use innovative solutions, apps on their phone that could help service them in the home, remote care monitoring technologies. When you think about perhaps less innovative per se, but when you think about electronic medical records in general, the ability to collect someone's longitudinal health record in a standardized way and report on that externally and internally to reduce then the patient's need to retell their story as they transverse through the healthcare system, not to mention through our four walls, is super powerful. Not only from a patient satisfaction and experience perspective, but from a medication errors, medication reconciliation perspective as well too. So certainly widespread benefits and patient outcomes that we see in some of those technologies. Fortunately as well too, the province of Ontario specifically had invested 10, 15 years ago in some significant infrastructure to help not only collect patient information on all Ontarians, but also showcase that and present that to physicians and nurse practitioners and other allied health professionals in the community so that, again, the patient's not having to retell their story as they transverse from home care to primary care to acute care. And so we're starting to see some of the benefits of that now, where some of those systems are starting to talk to one another, which has tremendous value, both from a provider perspective, because they're not having to re-ask, re-document those same medications, allergies, etc. But also from a patient's perspective, because all of that information carries with them. They can now have access to it through patient portals and other digital tools and really champion their own care, right? If they see a medication error or if they see something that is, perhaps of concern in their medication or their health history, they can have a question with their primary care physician, or they can reach out to a member of their care team and have that meaningful conversation. And so we're seeing a lot of that, certainly where technology has, again, direct benefit to patient outcomes, both on the experience and satisfaction perspective, but also direct health outcomes as well. The last thing I'll say too, fortunately, as I mentioned briefly, because of the pandemic, we saw a significant shift and increase in the use of virtual care tools, solutions, and so access to care is far greater than it ever has been. Notwithstanding, the point and the stat shared earlier around the proportion of people, Canadians, but also Ontarians, who do not have a primary care physician, those unattached patients, as we call them, significant issue, and something that a piece of technology or a digital solution will not solve. However, certainly having different ways to access the health system that isn't going to the emergency department is powerful. We see that in the data across the board. So
maybe a follow-up to that, just in terms of productivity. So in other words, technology is really increasing the productivity of
Yeah.
speed, right?
Yeah, absolutely. And there's something to be said about having, a satisfied clinical team and how that correlates to patient care. To Dr. Bell's point, if a physician is spending, say 50% of his or her time documenting in the chart, whether dictating or physically hands on keyboard, that's not generally what they want to do, right? They want to be either having pillow time with their children or pajama time, I think is referred to as, or providing direct patient care. And so where we can leverage tools for automation, there's huge potential there. I think we're only seeing the cusp of that right now.
Okay, thank you. The next question is for Luca, and appropriately because he's an entrepreneur in terms of barriers for a monolithic healthcare system. This has to do with barriers. What are the main barriers to the adoption of healthcare technology in Ontario?
Thank you for the invite. First of all, I really appreciate it. It's a pleasure to be here with Dr. Bell, with Justin, and with Elizabeth. I think I'm going to say something that actually, Justin, I saw a post that you made, which you're going to agree with me a lot, and this is what I'm going to tell you. I'm going to take two sides of the story. The first side, from the government perspective or from the red tape perspective, it's very bad, actually. It's a lot of barriers. It's very hard to convince physicians to adopt a new technology. And I'll speak from my own perspective and from my own story, right? I worked with my company in primary care specifically. And what happened with me was that my mom, who was a family physician, actually burned out and retired at around 45 years old. And I did some research, and there are actually 10,000 doctors in Canada who retire every year because of burnouts. That's a big problem, a massive problem, right? And we did some research with my team, and actually with also one of the doctors that is here in the audience right now. And we saw that one of the biggest problems was actually technology. They were spending a lot of time in front of the computer, inputting data into the electronic health records, instead of doing what they want to do, which is patient care. Just for perspective, I'm going to give you this statistic, was that a family physician, specifically a family physician, spends 17 clicks to go from the dashboard to prescribe a medication. And it does all that. Imagine 17 repeated stuff that they have to do in front of a computer. So we figured out we built some tools to make electronic health records a little bit more efficient, and we went in front of the physicians, right, in the clinics, and some of them loved it. They actually liked it a lot. But the moment that they say, "Oh, do I have to put another window on top of the EHR?" They leave. They ask me to leave. They say all the time. And this was something that I actually understood that's a big problem. And I see this with a lot of startups. So I'm going to talk about the first problem that is not actually a barrier problem, but it's more that the quality of the startups and the way that startups think in Canada. I'm sorry for my language right now. I'm really sorry, but it's bullshit. Like a lot of the AI that is built, it's very low quality data. They are not actually focusing on solving a problem for the physicians. And that's why you need a physician on your board usually to build this kind of companies, right? Uh, you know, I'm sure that you guys have heard about the new hype right now. Everybody's building a scribe company, and that's actually a very good scribe company downstairs, Clinical Assist. Amazing, amazing quality of data, amazing work. But you cannot build 50 scribe companies because the market share is very small. And I'm talking from a business point of view right now, right? Physicians are going to use just the one, two or three that are very good, which I think Dr. Bell also mentioned. UAGen actually built one of the best scribe companies out there, or scribe models, and it needs the term, right? What we're talking about today: innovation, thinking differently and doing things differently. Now, about a barrier problems from actually from the startup perspective as a founder, what I saw was not only family physicians, but we tried in the beginning, especially we tried with hospitals too. We said, you know what, this platform that we build, these tools that we build together, they can actually make sense a lot for also for the emergency physicians. So we said, you know what, let's go to the ER rooms. We talked with a director of a hospital in Nova Scotia. That's actually an interesting story. They told me, okay, Luca, you know what? I love the product. I love the idea. I love that you are building a lot of different tools, AI tools. AI was big at the time, especially before 2 years ago when it just started. And they told me, but do you know how much time we need to adopt this technology in the whole hospital? I said, you know what? 6 months, more. A year, more. 3 years, more. 5 years, more. 7 years, even more. 15 years to adopt it in the full capacity in their hospital. Uh, and that's, in my opinion, that's a big problem to build the technology, to bring technology to the hospital systems, right? So I think there is a lot of red tape, especially in Canada. I think there are some things that can be done. Of course, I don't have the expertise to say that, but uh, the good news is, of course, there is also a good news. There's been quite a lot of funding also from the government, actually, especially with the last bill for 2.4 billion for AI startups, and a big chunk of that is going through healthcare, actually. So that's a very good initiative towards bringing healthcare innovation and disruption into the economy.
Thank you very much for that. The next question is for Elizabeth, and it's so all the good that we see in what we're talking about, there's also technology wise. It brings me back to hacking, because you have privacy, people have records. A story comes to mind, I think it was out of California, University was hacked, and I think the hackers were extorting for bitcoins, for example, or something like that. I think it's University of California, Berkeley. So this question relates to privacy, obviously. So how can healthcare providers address privacy concerns related to the use of digital health technologies?
Yes, thanks for the question and thank you for having me here. I think this is an amazing event and I'm so happy to see everybody here. This is privacy and security in healthcare is job zero as far as we're concerned. And most people working in healthcare right now are clearly seeing that importance. So at AWS, for example, we secure most of the major banks, military, and in fact, even countries' sovereign information. So a good example is Ukraine, when they were actually going through their war, decided that they were going to hold on to their census data. And AWS went and worked with them and said, that's probably not a great idea. We really want to safeguard this for you. We will hold it for you, maintain it for you in your sovereign space, but nobody will know where that location is. And we'll safeguard it for you. And also went in and helped establish all the banking so that it was secure and the healthcare. So there's really important cybersecurity and infrastructure plays that are going on around the world. And that's what I wanted to actually emphasize. Everybody's probably saying, what is Amazon doing in healthcare? And AWS, particularly, Amazon Web Services. So we actually and Amazon took that infrastructure that provides you with all the boxes that show up at your door with a nice smiley face, and uses that same infrastructure and opens it up to customers worldwide to have the highest cyber secure platform on the planet. So we now make that available to governments and healthcare customers so that they can actually secure their data on a secure platform in the cloud. So this is how we actually maintain the highest integrity according to all of the PHIPAA and all the latest legislation. We also influence that legislation by working with the leaders around the world, like the Canadian Center for Cybersecurity, and actually get them to actually improve their stance on cybersecurity. I'm going to tell a story because privacy and security can be a little bit dry. But when we look at what that actually means for your patient information, if your patient information gets hacked or stolen, that's one thing. But if your local hospital goes down and they can't actually service you because they have been hacked, that means that surgeries aren't going on. That means that no appointment visits are going on. And this happened in many, many jurisdictions across Canada. In fact, we're a target globally for cybersecurity, and we've actually had an increase of over 80% of hacks and cybersecurity incidents in Canada alone. So we absolutely have to improve our stance in cybersecurity, job number one. Newfoundland, for example, was hacked so severely that they couldn't offer surgeries for over a week. So that's a patient safety issue. These people are actually going to have bad patient outcomes when you can't service them. So job zero for all governments right now, working with AWS across the country, is securing their infrastructure. But what this actually leads to then is great. So now you have secure private data that's held in Canada that we actually manage ourselves, and we encourage our customers to take the highest stance and encrypt that data. So it's secure, it's safe. What do we do now? Well, we want to start innovating, right? We want to start using AI, as Bob was talking about, in terms of great examples of how you can make that more efficient. Justin doing some amazing work in that area as well. We are not going to solve the human health crisis without innovation. In fact, if we don't start doing things differently, we can't hire enough doctors, as Gus was saying earlier today, to cover that gap. We know that we have a shortage of 30 million health tech workers right now, according to the World Health Organization, let alone the doctors that need to actually do the clinical work. So by innovating and creating new ways of doing things and using AI and technologies like that can do it. I'll give you another example of where we're using AI, and we have a cloud innovation center attached to the University of British Columbia, and it's all open source. So you can do projects there, and you're supported by the university, and then you can release them to the world open source. For $11,000, a physician clinician from our University of Waterloo, actually working at University of Toronto right now, discovered all the new variants for COVID. It was called the Ceratus Project. And then he released them open source to the world so they can actually develop the vaccines. This is the power of technology and coming to help and bring to bear on innovation. And I'm looking forward to more examples like that coming from this innovation hub.
Very good. Thank you. Kind of summarizing, because I know we come back to this monolithic healthcare system and the bureaucracy. And we often compare ourselves with like the publicly health system of Canada versus the United States in some cases. So this question is, I guess pretty much anybody can answer, but I'll direct towards Dr. Bell. What role should the federal and provincial government play in promoting and supporting the adoption of healthcare technology?
Yeah, well, the examples we've been talking about today are all examples where innovation has served the customer need, right? And when you're actually doing something that makes a physician's job easier, allows them to be more productive, or makes the patient experience better, you tend to get a bit of a clamor for that product. And, the examples, the scribing services using AI, the getting your radiation treatment faster, there's been no trouble with getting those products developed because quite often they often save money. So the example of Medley at UHN for treating patients with heart failure, if you can reduce hospitalization by 30% for patients with heart failure, you're creating an enormous opportunity to invest in innovation. And most innovation should be cost effective as well as effective. That's been my experience. What should the government do to encourage the development of innovation? I personally don't think very much. We've got great universities, we've got great research hospitals that are stimulating innovation. The idea that the provincial government should pick winners by reaching out and pulling innovation into the hospital with some sort of designated budget, I think it's a bad idea. I think that's going to tend to develop innovation that's not effective and not cost effective. If innovation doesn't save the government money, it's probably going to be slow to adopt.
It's not innovation.
Yeah,
It's not innovation.
exactly.
It's a kludge.
It's a club.
If I can actually just add on that as well too. I think I'll say it bluntly. I think sometimes getting out of the way is the best thing that can happen, right? I think removing themselves from the equation often establishes a bit of a sandbox that we can play in without any constraints. Certainly, funding helps serve as a catalyst, but it isn't often necessary, right? I think it's really bridging those connections between a buyer or a person with a need, a true defined problem that they're trying to solve, with innovators, tech and non-tech, and looking at where there's potential synergies there and growing that, co-designing those solutions.
I'm just going to add one thing on because I should say the federal government has an important regulatory role in ensuring things are safe and do what they're supposed to do. So that is an important role. And, people need to get their products approved for sale at Health Canada, and that's very appropriate to protect consumers.
Yeah, I think I remember a book that I read many years ago by Rosabeth Moss-Cantor, When Elephants Learn to Dance. And it kind of brings up this bureaucracy that her conclusions were that these organizations or companies that get too bloated and too big, they don't know how to dance to the innovation tune anymore, and they get outdated quickly. So that's something I need to touch on. The next question is an implementation question for Justin. It's what are some of the best practices for implementing healthcare technology in clinical settings?
Yeah, so where do I start with that? I think first I'll say acknowledging that implementation of any new technology, hardware, software, or combination thereof, represents a change to clinical practice, change to workflow, change to an individual, a change to a team. And so making sure that, first and foremost, that what the potential innovation is or the solution that you're looking at is squarely aligned to your strategic priorities as an organization and or is solving an operational challenge, problem, gap, whatever you want to call it. I'd say that's ingredient number one. Ingredient number two is, kind of builds on some of the sentiment we were hearing earlier, and that is taking a very pragmatic and deliberate approach to project management and also change management. The two are often used synonymously, but again, because this is a change, we need to be mindful of not only the process and the technology change, but the people change. How are people actually perceiving this? Is it welcomed? What's in it for them? And working with those key stakeholders, those interested and affected parties from the start right through to the end of your go live, but also operationally as well. I think the third I'll say is spending some, the bulk of your time up front in that planning phase. So making sure that you truly understand current state workflows, future state workflows. You have a clear understanding of requirements. To Elizabeth's point earlier around privacy and security, making sure that you're taking a very deliberate privacy by design approach in the implementation of that new technology. So involving your privacy and your security stakeholders from the start, making sure it's not an afterthought, because I can guarantee you it will come to a grinding halt if you don't do that. and making sure that you embed those policies, those practices, those safeguards into the design of that solution and into your implementation approach. Strong leadership and governance. I should have said that probably at the top, but if you don't have strong leadership, and that could be business, could be clinical, often both, and that's important too when you're looking at a technology in a clinical setting, is there's not only do you need that clinical champion who could stand behind what you're doing and speak peer to peer to their colleagues, but also a business lens on it as well too. And that often, in our world, in a hospital, it equates to a CIO and usually a chief of staff combo is what happens. Talked a little bit about privacy and security. I'll emphasize that again. I think there's a lot of strong frameworks. There's a lot of policies, procedures, documentation, notwithstanding our governing kind of piece of legislation, particularly in Ontario. Personal Health Information Protection Act, while dated 2004, is in the process of modernization. And so I think, working within those constraints and making sure that our patients' information that we are custodians of is truly safeguarded and protected from potential outside threats. And finally, the last thing I'll say, I guess this is the sixth item, operations and sustainment. So we put a lot of effort into the implementation, planning, the governance around that. Teams walk away and it's like, oh, how are we measuring success, or who's overseeing this? Or so thinking about that sustainment model, not only the financial resources but the people to ensure that is successful long term, and that you're able to optimize that investment and look at QI opportunities, quality improvement with that.
So the next question is for Elizabeth. And as a publicly funded healthcare system, we look to the private sector. So the question is related to can the private sector, in terms of the innovation that because the market's ruthless, so they have to be always innovating. It's a question about public-private partnerships. So what is the role of public-private partnerships in accelerating healthcare technology adoption?
Thank you. I love this question because, of course, this is our space that we're all working in. And I can say, as Dr. Bell was emphasizing, things have shifted a lot. So no longer are governments trying to do everything themselves on their own without involving private sector. It's absolutely the time of partnership and collaboration. So governments are looking to private sector to actually help them. Nobody has the capacity. By the way, I've never gone to any public sector customer across Canada and they've told me, yeah, don't worry, we have tons of people. Lots of people lying around. They're going to be able to work on this project, no problem, right away. It doesn't happen. It doesn't happen in the private firms and consulting either. It doesn't happen at AWS. None of us have enough people. This capacity issue is really, really important to tackle. So then, I think the real success comes when you can actually partner and you can help public sector customers actually solve their problems. And all governments are now used to that model. COVID was a game changer, and in a very good way for digital health, because all the things that we'd been building and wanting to move, like electronic consults and virtual care and other examples, actually happened. And all of a sudden people saw the value in them. And thank goodness we'd been working on them 10 years previously, Justin, Dr. Bell, others, and they're ready to go. So the governments themselves are very used to dealing with this. And almost any deal, I'll tell you, that goes in a public sector setting has a combination of private sector and public sector. And we are looking exceptionally at that win from a patient outcome perspective. We're looking at saving costs, obviously, for Ontarians, but most importantly, we're really looking at speed and agility. That is really how we actually need to work in terms of delivering better care in Ontario. So one example of a great public-private partnership, COVID came along, Ministry of Health really needed a COVID management system. They needed you to get your messages on your phone when you're going to go get your shot and where that shot will be. That was put up by AWS in partnership with other firms. And we're not talking in a matter of months, years, we're talking in a matter of days. And when that innovation started to happen and it started to be palpable for all of us working in public sector, it was really the time when I think it was exciting. And I think that has continued and in fact increased. Now with AI coming on board, there's also no customer looking at us saying, we want to learn about AI. Everybody wants to know about AI. And to get to AI, you have to have a certain maturity in terms of the technologies you're using. So it is a wonderful time. There's a shortage. We are probably, I would say Canada needs to perform better. I will be critical of ourselves. I think from a public sector pay for performance perspective, we have more to do. We are lagging behind the US. Right now, we have, I think, about 30% adoption of AI in Canada in our market. The US is already at 78% if we're going to actually compare in healthcare. So we have lots of room to grow, lots of room to move, and lots of demand. And of course, so there will be no shortage. The challenge is working backwards from the problems. And this is kind of what Justin was saying. So it doesn't have to be these mega projects. It can be very, very, very fast and small solutions that actually lend themselves to helping in a very big way. So I also want to emphasize it doesn't mean you have to be a massive, massive infrastructure hyperscaler like AWS. You can be a very small niche builder and be very successful at building a solution on AWS. Moreover, training, the last point, huge. Because if we can't figure out how to train people around the world, AWS has a training target of 25 million need to be trained by 2025. We believe in building those skills and capacity across the board for free. So there are over 600 courses that are available online. Just look it up, AWS training and certification, and you can actually access that training. And I think the training part of this and the success that you're going to find is going to be actually in the training component and bringing those skills along as these students are coming through and as these projects are going forward. And we're there to support you in that as well.
Final question will be to Luca. I have a question. It has to do with pilot programs. How effective are pilot programs in evaluating and refining new healthcare technologies before wider adoption?
Yeah. Before that, I just wanted to pick a little bit on the justice because I really like that what he said about the government, leave us alone, right? It reminds me of a history lesson. I'm a big nerd of history. So before French Revolution, Louis XVI told the Minister of Economy, bring all the business people together and ask them, what do they want from the kingdom? I know obviously he's laughing right now because it's an economy thing. And he said to business people, what do you guys want from the government? And the leader of this businessman gets up and says, leave us alone. God damn it, leave us alone. In that point, Dr. Bell actually talked about regulation, and that's the main job actually of the ministry and of the government. And I agree with it. A lot of entrepreneurs would say, "Yeah, regulation sucks," blah blah blah. I think it's important. I think it's very important. The journey of a founder, especially a healthcare founder, it's a journey of it becomes a philosophical thing. It's a journey of a constant suffering. When I said before of this rejection that we had for family physicians, there was a good sign. It was a good sign. It means that we're not building the right thing. And I'll talk about pilots right now in a second. There's a quote from where I come from. I come from Albania originally. We say, if you go in the forest, prepare to meet the bear. If you want to build this company, you want to bring the innovation and disruption of the healthcare system, you have to prepare. You have to prepare for regulation. You have to prepare for everything that can happen. So about the pilots, so just a backstory also, Agostino was my professor actually. So I'm going to bring us a lesson that he gives us in class. He told us, the first step is to get out of the house or get out of the office and ask people, validate. And I'm really obsessed with the validation process. Asking physicians, what do they want? What is the problem that they're having, right? There's a great book, The Mom Test, who taught us that. 80 pages book. I really recommend everyone that wants to build a startup to read that. The way that you ask the questions to your clients or to your customers, to potential customers, if you want to solve the problem, it's very important. That's the first thing, right? That's the first thing, the journey to go to the product market fit, right? And then after that, of course, physicians are very important. Having a physician on board. I'm really a big fan of having a physician on board because, especially when we talk about digital health, because that's the only way that you can actually understand very well the language that you're speaking. I organized a digital health conference last year and in Toronto, and we had around 10 startups who pitched. One of them was also my company, and another company is also today here, Clinical Assist, as I said before. From all of those 10 startups, Only us two, we had a physician on board. 1 year later, only 1 year later, all of the eight startups failed. Only 2 startups just continued to be alive. Mine and the clinical assist. Imagine, it's an insane statistic. It's proof of life, right? And to talk about pilots are very hard. We had I had to iterate at least 3 times. In the beginning, we started as a telemedicine company. It was beginning of after COVID. Everybody started to become a telemedicine company. We failed. We failed. It didn't work because, again, going back to my example, we had a lot of telemedicine company in the market. Then we tried this tool thing and just tools, right? As a new dashboard, as a new window. It failed again. It doesn't work. It doesn't work because of the problems it said. And I learned a lot. It was a process of a lot of suffering, a lot of self-doubt. A lot of people left my company, but at least we learned a lot. We learned that in EHR, a physician spends around 17 minutes per encounter in front of the electronic health record system, which sounds good, right? Inputting data. Only 3 to 5 minutes with a patient. So that was a problem. That was a problem. Again, technology became the problem. So right now we are focused a lot on we changed completely our business model and idea. We're focusing on automating a lot of these workflows, like inbox management or patient intake forms or even billing, and helping the physician or helping to be more fair, helping the EHR becoming more efficient. So I did a huge pilot, and people that knew me then are gonna laugh at me, especially Gus Agostino. I called and I had to talk with around and to try the demo of the product, 200 physicians, family physicians, which is insane. It's very hard. So imagine how many rejections I had. People call me kid all the time. They call me, oh yeah, this guy again, just let him outside the road, right? But it's needed. Again, it's part of the process. If you going in the forest, you have to expect to meet the bear.
Thanks, Luca. Always an insightful. Also, one of his teacher, but he's going to be on Dragon in the fall.
Yes.
Somewhere there. So, thanks for the Dragon. So thank you very much for that. That concludes the formal part of the presentations. Now I'm going to open it up to the audience.
Yeah, thank you everyone. Thank you for all the speaker. It's very informative information. My question here is touch between Luca and Justin. So let's assume we bring the cutting edge solution and we will give it for the end user, but based on the challenge they have the shortage and they know this is what might take a long time. They know and in the long term this is will give and benefit for them and it will help them. But with the short time, with good faith maybe they will resist and they will not go for that. So you talk about the change management, and when we talk about change management, mainly we are focusing into the health practitioner. Also, we need to think about the patient. So, from your experience, especially after the COVID in Ontario, so I don't know, Luca or Justin, anyone from you, how the culture, especially it is aging culture here in Niagara region, they are adapt to change, and also the healthcare professional. I know there's a new software. It's coming in down the road in Niagara Health. So, how you can make the change management, you will get it without any resistance, either from the patient or from the healthcare practitioner.
Steve, what is it?
Yeah, I'm happy to.
Yeah, sure, please.
Yeah, so if I understand your question correctly, and thank you for that, by the way, you're looking at sort of the perception or the reception of particularly patients to new digital technologies. Is that kind of the gist of it?
Yeah.
Yeah, so I think it's particularly at Niagara Health, as you point out, we are in the process of implementing a new electronic medical record. So moving from, circa 1995, largely paper-based environment and old systems, very much fragmented, i.e. they don't talk to each other, to a completely modern, fully integrated, enterprise-wide electronic medical record. Drastic change, but also significant benefits attached to that. So when you think about the patient's perspective, they now will be able to access their health information because it's all electronically documented. And so benefit there. we're going to be investing in several other, what I'll say, peripheral technologies on top of that electronic medical record that will help service patients and their needs. We work very closely with our what we call our Niagara Health Engagement Network. So it's effectively a group of patient family partners who really help to steer and advise us as a hospital on where the priorities are. And certainly, access to care, avoidance of the ED, the ability to book appointments online for ambulatory procedures, or the ability to have wayfinding tools or to manage that appointment, so you don't have to pick up the phone and call switchboard and be routed 6 or 7 times. Seemingly little things like that have huge impact from a patient's experience perspective, is those types of things that we're going to be focusing on and that we're really excited about.
Yeah, Justin, actually at Niagara Health, they're doing an amazing job. I work with Frank from Ontario Health Teams at Niagara Health. Yeah, great organization. From our end, and what I'm going to talk a little bit more, because Justin touched a lot of points that I wanted to make too. But from my end, what we figured out is that we've doing those changes also. What Justin was talking with inbox management and billing and everything like that, we can save doctors a lot of time, and we can save them around 2 hours per day, which is insane, right? And we can increase their revenue by $1,000 per day just by doing that. But concepts are very important. I really like to talk about concepts, and a concept that I usually talk in panels is a new concept of individualized medicine. We have learned about precision medicine. We have learned about personalized medicine, which is basically bringing some groups together, Luca and someone else. It's very similar health attributes or health parameters. So we target a drug or target a treatment towards that. This new phrase or new concept came out of Mayo Clinic, I think, and they talk about individualized medicine, which is Luca, a treatment. It's basically targeted to Luca's health, so a guide to your own health. So that's where the future is going, even in the patient. Patient matters, more preventative care rather than reactive care, right? So I think that's where a lot of people should focus, in my opinion, at least.
Yeah, I might add a little bit too on where it's going from. You mentioned the aging population. So actually supporting patients outside of a hospital is what a sign of a really highly functioning and performing hospital. They're now actually figuring out, let's actually service those patients as much as possible in their home, maybe monitor their chronic diseases at home. Dr. Bell mentioned Medley, one of them. So this whole remote patient monitoring and actually creating a home where we can monitor your vital signs and actually have ambient listening like Alexa to actually hear you talk to the doctor, who could then actually, just by your voice, Alexa could tell if you're actually getting worse or better before the physician even talks to you. So there's so many ways that I think technology is actually going to shift the adoption and actually change some of the nature of why we even need to visit a hospital in the first place. That will help a lot.
Thank you very much. That concludes our panel session. So thank you very much, everybody. Look at an amazing panel. Please follow him on LinkedIn.
Salmon.
Read some of his amazing books too, Dr. Baldo. It's great. And like I said, again, follow up with
Good to see you.
Thank you so much. Quick intermission. We'll start the next in about 5 minutes or so. Who is better than?
Yeah, I think you guys can line up here to
Perfect. I was trying to
Round two.
because that was our script too. And
Yeah.
hey, do you guys want this?
I've been-
Do you guys want some more? Yeah, anybody? Very good wine? No? No? Food? Perfect, yes. Okay. Are we good now, cameras?
I'm good, yeah.
Okay. Well, welcome everybody to the Food is Medicine panel here. Panel that I'm very passionate about, and so are a lot of the people here too. And what's interesting today is that we have a group of eclectic and very intelligent people that have experienced food as medicine in one way or another. And what's very important is we actually have doctors here today who perhaps were more traditional in their approach to treatments of certain diseases and certain illnesses, who have now turned with a little bit of more interest into food as medicine and realizing the properties that it has for treating, healing, and living a healthy lifestyle. So I'll introduce everybody too, and then we'll go through some of the questions. So beside me, I have Dr. David Deiter. Dr. David Deiter's research focuses on secondary health complications of spinal cord injury, including chronic inflammation's impact on physical and physiological outcomes, cardiovascular disease, and sexual function. He directs the PowerCore program at the Brock Functional Institute Inclusive Training Center, or BFIT, providing wheelchair-accessible exercise programs for various conditions like spinal cord injury, multiple sclerosis, Parkinson's, and amputees in the Niagara community. Welcome, Dr. David Deiter. And next we have Dr. Poria. Dr. Poria is the CEO and founder of Canada Clinics, leads a network of serving thousands of Ontario patients since 2017. He's the poster child that they were all referring to as a graduate from Augustus Medical School, and made that treacherous climb back into Canada. He combining his medical background with entrepreneurship, he cultivates partnerships to benefit patients and providers. Pursuing an executive management degree at MIT Sloan School of Management, he's passionate about AI's application in healthcare. Dr. Poria holds a doctor of medicine from Saba University School of Medicine and is certified by the College of Physicians of Ontario and the Medical Board of California. Welcome, Dr. Poria. Next, we have Elizabeth Macnica. Elizabeth, our counterpart from the United States over here, is a dedicated public health dietitian with extensive experience in nonprofit management, academia, and research. She currently serves as an instructor at Dame University and directs health initiatives at Buffalo Niagara Medical Campus, one of the hub's partners, which provide an array of healthy living programs for clinicians, patients, and neighborhood residents. As founder of the BNMC, the Buffalo Niagara Medical Campus Food as Medicine program, Elizabeth addresses the leading cause of poor health through strategies rooted in food and nutrition. Her work is driven by passion for improving population health and quality of life. And then lastly, I'd like to introduce Dr. Faraz Masood. Dr. Faraz Masood is Distinguished General Internist at Niagara Health and serves as the Clerkship Education Coordinator at the Niagara Regional Campus. In addition to his clinical duties, he is an Associate Clinical Professor of Medicine at McMaster University, where he plays a pivotal role in educating and mentoring future physicians. Dr. Masood is known for his dedication to patient care and medical education, making significant contributions to both his local healthcare community and the academic field. And let me tell you, this guy's the hardest man in the world to get a hold of. And you get a headshot from him. And I know he's an avid cyclist, because that's the only picture I can find is him cycling. So I know, really, really excited to have this amazing group of people here. Like I said, all sharing a passion for food as medicine. So the way this is going to work out is I'm going to ask questions directly to somebody, but everybody's allowed to respond to that as well. And then, of course, we'll open up questions to the community. So the first one is to Dr. David Deiter. What is the scientific basis behind the concept of food as medicine? Are there any particular nutrients or food components that have been proven to have medicinal properties, especially in the research that you've done?
Okay, thank you very much for having me. This is a really cool event to be part of. And I should also introduce Dan. No one introduces the introducer. Dan was a grad student of ours in the kinesiology program at Brock. And we couldn't be proud of him for what he's accomplished and what he's doing here today. And the innovation. Very proud of him. So the answer to your question about the scientific basis and are there certain foods and nutrients that have medicinal properties and benefits? Absolutely, yes. The scientific basis, this field is, I think, actually much more well established than people may appreciate. There are hundreds, maybe thousands of double-blind, randomized, placebo-controlled trials showing the benefits of various nutrients, foods, and diets on many forms of health and disease. I actually brought it.
Oh wow!
Just a few that I grabbed because they're interesting, and that's some stuff that people may not really be that familiar with. Here's one that showed 30 grams of flaxseed over 6 months For people with hypertension, reduced systolic blood pressure by about 15 millimeters of mercury. Interesting.
I love black.
RCT. Here's another one showing the effects of turmeric powder in only 3 months of turmeric powder lowered hemoglobin A1C in type 2 diabetics by about 10%. Again, another RCT. Here's a cool one as well. Sulforaphane treatment for young adults with autism, just in the form of broccoli sprouts for 14 weeks, caused very significant decreases in problematic behaviors and increases in verbal communication. There is such a wide range of benefits of these nutrients, foods, and diets for such a wide range of health conditions, and so many interesting mechanisms involved. There's an enormous scientific basis for this food as medicine concept. If you want to categorize it, what are some of the actual benefits that some of these nutrients have? I'll just give a few. There's a lot more than this. There's a lot of foods that have very well established anti-inflammatory properties. So they can help either to prevent or reverse conditions where inflammation is the primary cause, actually, maybe something like rheumatoid arthritis, or help conditions where inflammation is a secondary health problem. Like in my research with spinal cord injury, it's a big secondary health problem. There's other foods, for example, that have very powerful antioxidant properties, which has a wide range of health benefits. Just for example, decreasing the risk of certain cardiovascular diseases, maybe by preventing the oxidation of bad cholesterol. And then another kind of cool one that is gaining more, I think, traction. A lot of foods have anti-angiogenic properties and have real kind of promise for cancer. The principle being that when a tumor starts off a certain size, it's somewhat innocuous. When it grows to a certain size, it starts releasing factors which cause blood vessel formation around it, and that's how we get it metastasizes and travels to other parts of the body. So there are certain foods, and that's called angiogenesis. There's certain foods that are anti-angiogenic that can halt the growth of the blood vessels and so help with cancer prevention or even shrinking tumor size. So there's a wide range of helpful properties of foods. Again, just some of the nutrients that we talk about: sulforaphane, which is in cruciferous vegetables, anti-inflammatory, anti-angiogenic, antioxidant properties. Thylakoids in your dark leafy green vegetables reduces fat absorption. Lignans in flaxseed especially has anti-cancer properties. Interesting one here, ergothioneine, kind of more well understood amino acid found particularly in high amounts in mushrooms, for example, especially porcini and oyster mushrooms, if you care to know, has powerful antioxidant properties as well. So there's a wide range of positive health effects. The research is very well established. How do you navigate all this? I'll just say quickly, because really when you say, are there medicinal benefits, you're really asking, what should I be eating? It's a very large field. It may be tough to navigate. If you want to boil it down to a sound bite that I think you can live by, I think the best sound bite I've ever heard was from Dr. Michael Pollan, who wrote The Omnivore's Dilemma. And he gives this advice. Eat food, not too much, mostly vegetables. And if you can live by that, I think you're probably 80% okay. If you want something a bit more specific than that, the best book I've read lately was by Dr. Michael Greger, How Not to Die. Dan's read it too, it's a big fan.
Favorite, yes.
And he breaks down a little bit more specific than what Dr. Michael Pollan suggests, but Dr. Greger breaks down the important foods we should be eating into his daily dozen. Serving of berries every day, 1 serving of cruciferous vegetables, 1 tablespoon of flaxseed. I can go on, but there's 12 of these daily dozen foods we should be ingesting every day. That gives you a wide range of far-reaching health benefits for many different conditions. And then the last thing I'll say, if you have a particular condition that you want to address, there are certain diets that have been put together that address certain conditions in particular. In my lab, we studied the effects of a 3-month anti-inflammatory diet for people with spinal cord injury. We did, in fact, lower inflammation. We took blood samples post to 3 months. We know we lowered inflammation. And we had 2 really big effects. One was on depression and one was on neuropathic pain. So there are specific diets as well that have been constructed that have medicinal properties. So it's a well-established field, might be hard to navigate, but there's a little bit of helpful advice, I think.
No, that's fantastic, and I can attest to that amazing book, How Not to Die. My grandfather passed away from colon cancer, so I wanted to get to the root of the problem. And what Michael Greger, Dr. Greger, what he argues is that cardiovascular disease and cancers, many of them are actually personally made diseases based on your environment that you would surround yourself in. And it's actually very simple to eat the foods that he says it provide daily does. You can actually eat it just in 2 meals with a smoothie and a salad, and then still have whatever you want for dinner too. So I highly encourage you to read that book. It was a life changer. I didn't read it. I listened to it because I have severe ADD and I can't sit down and read a book if my life depends on it. But it's a fantastic book. Next question is over to Dr. Masood. You worked as a cardiologist and worked with a lot of different patients. How can specific dietary changes aid in the management or prevention of chronic diseases, like we mentioned, like diabetes, heart disease, autoimmune disease, cancers, and different?
Definitely. Thanks, Dan. That's an awesome question. First of all, thank you for arranging this. This is amazing. That's particular topic has actually become a passion of mine. And so we all know we need glucose. And we know that glucose not only is a very important nutrient, but it is also, it's very important for energy needs for the long term. And actually, if you go thousands of years back, as hunter-gatherers, we depended on that because we went through a period of feast and famine. And feast, we will accumulate all that glucose, which will store up in our tissues. And when we went through our period of famine, we needed that energy to provide glucose to. Then happened agricultural revolution, industrial revolution. Last 50 years, we have just kind of started over consuming what we have right now. And so we have developed these conditions like diabetes, obesity, and that leads to insulin resistance, hyperglycemia, that is diabetes, and then diabetic complications, cardiac stuff, and all. And when I graduated from residency 15 years ago, we were taught that diabetes is an incurable problem. Once you have diabetes, you can never get rid of it. And we saw year after year, patients get started with one medication, which was metformin, and 5 years, 6 years down the road, there were like slew of medications, including insulin. But we never solved the underlying problem, and that was the consumption of bad food. And what it comes down to it, if I just put it down into a few words, is you have to minimize the use of carbohydrates. Having said that, glucose is still very important. But if you minimize carbohydrates, our body is still carrying that adipose tissue that breaks down and provide glucose to our normal functioning. That is the key thing that is there. Now, the low carbohydrate diet is a very broad term, and we have come up with these diets like Mediterranean diet, ketogenic diet, different kind of low carb diet, very low carb diet, depending upon the gram. But essentially, the idea is the same. If you are diabetic, if you minimize your carbohydrate intake, if you exercise and get rid of that excess tissue, you will control your diabetes. So that is the simplest thing I would say. Mediterranean diet. So in one of the studies, actually, Mediterranean diet versus a low-fat diet showed that in a newly diabetic, 44% of the people did not require medication as compared to a low-fat diet, the 70% required diabetic medication. And they were able to delay the starting of a medication by 5 years as compared to 3 years. So diet is the most important thing with respect to our things like diabetes. Now, the other thing that you mentioned, Dan, is heart disease. Now, heart disease is an end result of different factors. We have certain non-modifiable factors like age, gender, ethnic background, genetic background. There is nothing we can do about it. But the modifiable risk factors, including diabetes, as you talked about, high blood pressure, some water leaking there. For example,
Unless we got to be grateful for the water that's coming down.
So inflammation.
Yeah.
So the other thing I want to talk about is simple thing like, for example, the other major risk factor for heart disease, as you mentioned, is hypertension. And one of the most cause of hypertension is our salt intake. And if you look at it, we usually probably require less than 2,300 milligrams of salt per day. An average North American is consuming up to 3,500. Then 70% of our salt comes from food outside our houses, our homes. Right? And their studies actually, Chinese studies show that once we switch from 100% sodium chloride to 75% potassium and potassium chloride and 25% sodium chloride diet, it decreased deaths by 15%, decreased brain hemorrhages by 30%. And I can tell you, I work in the ICU in Niagara Falls. We have seen patients in their 40s and 50s with massive brain hemorrhages, which is actually a death sentence. So just by making a small switch from our table salt to a low, in fact, here we have a as a no salt or potassium chloride rich salt saves lives. Okay. And the other things, of course, the cholesterol is another issue in which we should be consuming low cholesterol diet. And Mediterranean diet is like less in red meat, more in white meat, like poultry or fish, and a lot of things like vegetables, fruits, legumes, nuts. This is the diet we should be consuming, as Dr. Dyer said, like unprocessed plant-based diet. Yes, we need meat as well, but that is the way to go.
Perfect. Now, I think, one thing that a lot of people wonder, you got simple carbs and complex carbs, and how do those differ with, keeping that glucose level, that homeostasis, if you will.
So, this for me, right?
Yeah, anybody. Yeah.
So simple carbs are essentially processed carbs. If you drink a glass of juice, that's simple carbs. That does not require any processing in the gut. It goes into your gut and it goes across the membranes into the blood, raises your sugar pretty quickly. The Cokes that we drink has that, right? Majority of the complex carbs comes from vegetables because plants are what? They're starch. They have the same things like as carbohydrates complex, which requires a lot of breakdown in our gut. So let me put it this way. So the simplest way our carbohydrates get into our bloodstream is by glucose. And when it gets into our bloodstream, they cannot differentiate whether the glucose is coming from a complex carbohydrate or a simple carbohydrate. But essentially, what we're consuming in our diet, if we are consuming vegetables, if we are consuming complex fruits, these are all complex carbohydrates. They have lower glycemic index. They don't raise insulin that much. So if we have to consume carbohydrates, we should be consuming complex carbohydrates that comes from unprocessed vegetables and fruits.
Perfect. Now, the next question is related to Elizabeth over here, and got to know over the last couple of years, and a phenomenal person who, has really taught me a lot on the properties of food as medicine. So, that being said, what strategies can be employed to educate the public about the benefits? So, like you educated me about the benefits of food as medicine.
Well, thanks, Dan. I'm really excited to be here, and especially with two physicians. It's so exciting. So I first want to preface that I'm from Buffalo, as Dan mentioned, and in Buffalo, food is medicine. You can't really have food as medicine if you don't have access to food. So I just want to share some context about our community in Buffalo and why food access is so important to food as medicine and why healthcare especially needs to pay attention to it, especially with how the mayor opened with 2 million, I believe was the number he quoted, residents of, was it Ontario or Niagara Falls not having access to healthcare? So think about how many of those residents do not have access to food, right? So in Buffalo, one of our most under-resourced and underrepresented communities in the east side of Buffalo, our food insecurity rate is about 30%. And the national rates, put that into context, is about 10 to 11. So if you don't have access to food, how are you supposed to benefit from all of these things that we're talking about here? And so food insecurity worsens any underlying disease that you already have, right? And so when we talk about nutrition and how we're integrating the food system within the healthcare system at BNMC, there's a few strategies that we use to do that. And when we look at food as medicine, it's sort of a spectrum, right? So at one end of the spectrum, there's these general population level approaches and strategies that you use to get most people to just prevent disease, right? We want people eating more good foods. At the other end of the spectrum, we have approaches that are actually treating, reversing, managing diet-related disease using food, similar to what colleagues have shared. And so in the middle, there's even more approaches. So we have this entire spectrum of food as medicine approaches, and education is threaded throughout the entire spectrum, not only for patients and community members, but also for healthcare providers. So in the United States medical education system, I believe doctors only receive about 19 hours of education about nutrition. And so having that conversation as a provider is really important. If they're not educated on the topic, how are they going to start the conversation with their patients, number one? And then number two, if they are talking about it, how do they know how to refer out, or what resources are available in the community? So our education strategies, we kind of have them at each level on the medical campus. The first is individual level. So we have a 40 Days to Wellness program that's open to healthcare workers, where they actually learn the information colleagues have shared about healthy eating. They get meals. They participate in culinary medicine, cooking classes. They get coaching from a dietitian and mindfulness strategies. So that's sort of just as a person, no matter if you're a healthcare worker, community resident, we meet you where you are and kind of guide you through those 40 days. The second level of education that we have is through our Food is Medicine Coalition, which so we bring together all the partners in the healthcare system and the food system, farmers, doctors. We meet multiple times a year and work on strategies for how doctors can actually refer out and integrate maybe farm box programs, produce prescription programs within the healthcare system. So we're working on building a sister coalition here in the Niagara Falls region with Healthify. So if you want to learn more, we would love for you to join and take part. So stop by at the table downstairs. And then the third strategy we use for educating is more so at the systems level. So that gets into our work with healthcare. We have an annual symposium. So this year it's going to be held in October, and the theme is culinary medicine. So that's the joy of arts and cooking blended with evidence-based science of nutrition. So you have doctors paired with chefs, paired with dietitians, all in the same room, cooking together, breaking bread over a healthy meal, and just focusing on that culture, building that culture of fresh, healthy, local foods in healthcare. So that's been some of the work that we found successful in Buffalo, and we're home to the chicken wings, so we feel that it works.
That's exactly it. No, and fantastic. I highly recommend you all visit the symposium in October. The Buffalo Niagara Medical Campus is a fantastic facility. You know, you think of us, like in everything in the States is always bigger and better. But yeah, they do a great job. And like I said, they're one of our partners, and we've been working with them for a long time. So I'll be there, and I highly recommend a lot of you go there because it's always a lot of fun. Next question is related, based on the education and educating patients. And what are some of the practical dietary recommendations that you can give? This is to Dr. Poria, to incorporate principles of food as medicine. I must say, obviously he incorporates food as medicine. He's actually 70 years old. And he just looks that good. No, but I had a chance to meet Dr. Poria a couple months ago. We actually have a podcast together called Chapters Beyond Medical School, where we talk about a lot of things that aren't taught in medical school. I mean, I don't really talk. He really just talks. But I know that question is directed to you. So, how would you as a physician, how do you incorporate some practical dietary recommendations for individuals while they're going through certain types of treatments?
Thank you, man. And thank you for putting this together. It's been an amazing event, and I've been talking nonstop, so sorry for the hoarse voice. There's so much to unpack on this subject. I didn't even know how to prepare for this because I could probably talk on it 5 hours and I still wouldn't get to a lot of
We got 5 minutes.
Yeah. Good thing I'm all talked up. But I'll tell you what, when we're talking about food as medicine, and we talked about this before, we can't ignore the fact, yes, food as medicine is amazing, but let's not eat poison. That's more important, I think, as well. So when we go to the grocery store and we buy our stuff, if we reach for the convenient stuff that comes in a box, that's been processed, that's been placed in a container that you can pop into the microwave, and if there was any nutrients in there, you're going to kill it in there anyways, and then you eat that, then you're eating literal poison with some calories kind of put in there to give you some glucose, not in a good manner, but you're really, and a lot of other things that do a lot of bad things to our body. So humans weren't designed to eat this way, right? There's been a lot of scientists who have dedicated their lives to finding out what it is. What is this longevity secrets. How can we live longer? How can we avoid heart disease and this and that and diabetes now is I read something. I still I don't want to believe it, but I read North America over 50% of adults now have diabetes. And over 50% of kids are at risk for diabetes. I mean, think about a population of your country, half of them have a disease that came from a food industry complex because the food wasn't intended to have nutrients for you to eat and nourish your body. It was meant to make some venture capitalists some money. So the food was grown to weigh as much as it can. Nobody cared about the nutrient it carries. Nobody cared about genetically modifying all the good stuff that our bodies have used for millions of years and adapted to it. But they thought, no, we're going to genetically modify all this stuff to take the seeds out of it so no one else can farm it. And we're going to make it weigh as much as it can. And then we're going to take that stuff and then we're going to process the heck out of it, put it in a box, and then add all this other chemicals to it that nobody can pronounce. I'm a doctor. I'm telling you, I go to the grocery store and I read the box and I'm like, I don't know what any of this is. Might as well just not buy it, right? Because now I've learned if I can't pronounce it, I'm not going to buy it. I'm not going to put it in my body. So this has been kind of my own thing, my own journey where I'm looking at my patients, and I have a lot of patients. I have thousands of patients, and I look at them, and I have a lot of Italian patients, and that generation of Italians are living in their 90s and they're still gardening and doing all the, pushing a wheelbarrow. And I just kind of like, what's your secret? They don't know, but I figured it out. The common denominator for everybody is that they're growing their own food, they're preserving their own food, and then they're eating that food
And cultivating it.
And the food is made with the intention of feeding nutrients to your family. So I think that's the secret sauce that we're all missing from our lives. And that's why we have diabetes and high cholesterol. And we can decrease our carbohydrate intake, but if we go buy that keto bread that is actually from processed soy and this and that and the other, you might think you're doing something healthy. I see my patients coming to me and say, I'm eating healthy, doc. I'm eating plant-based burgers. But there's 150 ingredients in there you can't pronounce. That's not actually healthy. There's 5 different kinds of food coloring in there. That's all poison. So how can we do that? It's really easy, actually. It's really cheap to do. Just grow your own vegetables in your own garden and then preserve them and then eat that and make sure that you teach that to your kids and they can do that and do that with your community and do that more and more to send a message to the food industry to tell them we don't want to buy your crap. Right? We need organizations like Food is Medicine to come in and put all these people together, and we need more nonprofit organizations to come in and educate our people, because it's not a prescription they need, it's an education they need, and they can heal themselves. Just eat right. So you named some herbs and spices in your research that that I can tell you 5 other things that each one of those will do that scientifically. So turmeric, curcumin, it has scientifically been proven to be better or at least as good as ibuprofen for relieving inflammation. It's way cheaper too. It doesn't hurt your kidneys, and as a side note, it'll decrease the rate of lung cancer, colon cancer, and a bunch of other stuff, right? So why are we as physicians not telling our patients to go buy some, turmeric powder, turmeric and ginger in its natural form and just make a tea out of it and eat that. I've been telling my patients to do that. And you know what? I thought they're going to think I'm a lunatic, but I can tell you that I've had more positive feedback from this than anything I've ever prescribed. They come back and they thank me and they say, you know what, thank you. Like, I didn't even know it even cured my back pain. I was taking it for something else and then it cured my back pain too. And they still don't know that, they might have had some kind of cancer that it also prevented as well. So yeah, we can eat it. So how do we do it in a 5 minutes, segment? How do we do this? So eat a rainbow color, vegetables and fruits and all of that stuff, and try to get the stuff that haven't been genetically modified and messed around with. Grow it yourself if you can. Eat with mindfulness, right? So all these scientists went into these crazy places in Amazon to see why there is literally zero heart disease in this community. So what they actually realize is that it's not what they're eating, because they're eating similar. So they're eating carbohydrates. They're eating like potatoes. They're eating rice. They're eating the pig that they slaughter. So what is it? What's the difference? So they realize that it's actually their cooking is 1 or 2 ingredient cooking, and it's not fried, and it's some kind of soup or whatever. It's 1 or 2 ingredients in there. There's no salt. There's no other things they're adding to it. And they're just eating simple. And because it's so bland, they're not eating too much. So eating with mindfulness, you're not eating to please yourself. You're not eating because it tastes good. You eat as much as your body needs and then you stop. And if the food doesn't taste like amazing, then you're only going to eat as much as your body needs. If they just gave you potatoes without any salt or anything added to it, you would just eat as much as you need. And that's the key, right? Just eat natural ingredients as much as you need, and don't overcomplicate it. Don't buy the box off the shelf, right? Make it yourself.
That's great. And if you have 4 hours to listen to our podcast,
To be continued.
No, awesome. And I completely agree. Like I said, I make a turmeric tea every single morning, and it certainly helps.
So do I.
Yeah. Inflammation too. So next is get back to Dave talking about research. Now we noticed that there is some research on simple herbs and types of foods too, but there's gaps in this research too regarding food as medicine. And I feel like a lot of the gaps is they're talking about what's good for you, but there's no research on what's bad for you.
Sure.
Right. And what are those gaps in the research, and how can those be addressed?
Sure. Yeah, I'll talk about that. First, I just want to echo a little bit of what Dr. Correa said. So he's exactly right. Food is medicine. There's so much food out there that has medicinal properties that we should be trying to eat as much as we can. But there also are foods out there, more of them even maybe, that are poisonous for us. And sometimes you read, this kind of really strikes you when you read certain research papers. I'll just give you an example. 2 different diets for MS. One is the Walls Protocol, one is the Swank diet. You couldn't have 2 more different diets, and yet they both show positive effects for MS. You think, well, why is that? They look so differently. Maybe because neither one of these diets has any crap in it. And so it's not only important that we get these healthy nutrients in us, it's maybe equally important, possibly more important, that we avoid all the poisons that are out there. And also, just like Dr. Correa said, these come disguised a lot of the times in the grocery store. They're so well marketed about how you can think you can be eating healthily, and in fact, you're not. And there's lots of examples of that. Try to shop in the perimeter of the grocery store. Try to stay out of the middle of the grocery store. If you can't grow your own plants at home, go to a farmer's market. Go to the bulk barn. I actually started shopping at the bulk barn. It's one of my favorite places to go shopping. It's much actually cheaper to eat healthy than it is to eat in an expensive way as well. And once you get used to it, it just becomes part of your daily cooking routine, just like anything else did. It's no more inconvenient. Now I'll get to the gaps in the research. Sure. So just a few things that are, I think, interesting to talk about in research. Okay, so one I think that's interesting that we maybe don't pay enough attention to is that, for example, when I look at a grad student's results, it's interesting. They get very proud. We read a study and you see that maybe some kind of nutrient that we ate, had an effective, maybe lowering, like I said, hemoglobin A1C. And you got a nice bar graph and it shows that it's decreased. Those averages that we report pre-post are super and they're important. But don't forget to look at the little error bars that are on top of each one of those little bars in the bar graph. And that shows you the variability in the response. So we have an interesting kind of phenomenon where we get responders versus non-responders. We get it in exercise. We also get it in nutrition. Sometimes the responder versus non-responder issue, I think, is real. I think some people are maybe genetically predisposed to having a greater or lesser response to some kind of nutrient. And sometimes it's because our research isn't designed as well as it should be, which is not always the fault of the researcher. This is just difficult. When you're talking about, for example, in my field, trying to deliver a diet, which is a long-term intervention to a special population, that is such a challenging thing to do. It's not like we have hundreds of thousands of these people at our disposal. We can easily call them on the phone and say, come in my study. And once they're in the study, the few that we get, it's tough to stick to a dietary intervention for 3, 6 months, a year, possibly. So how do we help this? Multi-center trials. So first of all, we need to explore the responder versus non-responder phenomenon. We need to know why some people are responding, why they're not responding. It'll help us tailor our diets and nutrients to people. We need to do multi-center studies because in my field, for example, I don't have thousands of people with spinal cord injury or MS at my disposal. I have a handful and I do my best with them. Those studies are much better when you got cooperation from other centers as well. So multi-center trials. In the same way, we need meta-analysis. I read you 3 very interesting kind of randomized control trials. The king of studies, a randomized control trial, but we need meta-analyses and review papers, systematic reviews to take all this information and group it together. So we get hundreds of thousands of subjects in a meta-analysis rather than 35, for example. And then I think a big gap in research, and again, I really want to echo what Beth said here. A lot of what we do in research is physiologically based. We give someone an intervention and we look at their physiological responses to it, and that's very much needed. But we also need practical studies on how to deliver this information to people and how to help them stick to these diets that we've discovered are beneficial. So I've got a good colleague of mine, a good friend of mine, Sean Locke. He's a new prof at Brock. He says this very well. Gathering information about healthful eating is actually the easy part. Sticking to a diet long-term and making a lifestyle change is a much harder thing than collecting the information for yourself. So we need behavior change studies. We need behavior change coaches. I'm also involved in the Healthify app that you'll see downstairs, and that's one very, very important component of it. We're not just guiding people through what to eat. We have behavior change coaches to help them stick to this advice long-term. That could be anything from, reducing geographical barriers or financial barriers, decreasing food insecurity. It could be helping people with meal preparation, knowledge about meal preparation. In my field, it could be as easy as showing someone some accessible kitchen equipment. If they've got reduced hand function, you can't cook easily, you can't shop at your house. Here's some products you can use. So we really need that behavior change research as well. The last thing I'll say, do we need a lot of research on, because what a lot of people get tempted by is, okay, we found out that broccoli is good for you because of these sulforaphane. So it's raining on us right now.
Yeah. Condensation.
I'll see this last thing, and I'll see this last concept, and I'll end with this. Do we need a lot of research? And this is very tempting for certain companies out there, do we need a lot of research into how to extract these nutrients from foods and put them in a pill? And I'd say no, we don't actually need a whole lot of that research because there has been study after study after study that has shown when you take the nutrients out of these whole foods, they're either not as effective or not as effective or not effective at all. One quick example, there's a study done with black beans to show that they had an anti-inflammatory effect. But if you give people the exact same amount of fiber or antioxidants that were in the black beans, they actually lose, or even combined, it loses the anti-inflammatory effect it had before. There's something about the matrix of whole foods which is good for us, and extracting these nutrients, I'm not so sure we need a whole lot of research in that area. So anyways, I'll end with that.
No, and that's perfect. That brings us to the next question with Dr. Masood is that, you're dealing with a lot of patients all the time and you're recommending food as medicine change. But, what are some of the biggest challenges with these patients adopting this as part of their, medicinal
Great question, Dan. So I think if you look at a mega level,
Yeah.
I think one of the biggest challenges is the support from the government. I'll give you a stark example in just down south. In September 2002, President Biden held this conference in White House, which was called the White House Conference for Nutrition, Hunger, and Health. And it's so apt that the motto of that conference was food as medicine. And they invested $8 billion on it. So coming from the federal government, $8 billion in partnership with universities, in partnership with pharmacare, and with the local communities to make sure that there's no that they decrease the rate of like hunger, provide better sleep, better health, and they actually the focus is to reduce the incidence and prevalence of diabetes and heart disease. So that is coming at a federal level. And to my knowledge, correct me if I'm mistaken here, I don't think so. We have anything remotely like this in Canada, right? So that's the biggest thing. From at a very personal level, when I talk to my patients one to one, and I think there are two major challenges. So one of the challenges that I think alluded to is we literally have zero training about nutrition in our med schools, in our residencies. I do not remember anything knowing when I graduated from my residency. And actually, there are research done, and only in the licensing examination, there's only 1% of questions that are based on nutrition, only 1%. And majority of us, including myself, got that knowledge after I started practicing and I started seeing my patients. And it's also partly driven by your own health, right? You are aging every year. So that is a major factor. So this is a huge barrier that we are not being taught about these things in med schools and residency, and whoever has interest, they just kind of delve into it, learn about it, and impart the knowledge. Second thing is the patient specific issues, and I think I can identify two major issues. One is the knowledge, and the other is a resource. Knowledge, for example, we all go out, we all get groceries, and we all get box cereals or bread, and we all look at the food labels, but how many of us know when it says 20 grams of carbohydrates? What does that really mean? How does that mean to me how much sugar I'm going to get out? And when I talk to patients, I said, do you know this box of cereal that you're having in one serving is going to give you 5 grams of sugar? Now, if I ask you to take 5 grams of sugar from a teaspoon, would you take it? I said, no. So what is documented or what is labeled, we are not converting it or we're not translating it into tangible terms that we can understand. And I think that's a major disconnect, and patients don't get it. And they go for labels like low sugar diet. Low sugar does not mean anything if it has too much carbohydrates in it. Right? So that's one thing. Second thing is, of course, resources. I have had patients who don't they don't have money, right? You can buy McDonald's for $4, but if you have to buy a Mediterranean diet, and if you have to do that, you have to get berries and nuts, and all that, it gets a lot of money. Right? How do you do that? I have young patients, 13, 40-year-olds living in Niagara Falls, single mothers, young children, they can't afford it. How do you fix the problem? Right? So these are all the things that need to address. Some of them can be addressed at a very individual, personal, clinical level by myself. Some of them are beyond our control and probably need more help.
No, that's fantastic, and that brings to the next question for Beth. And what are some of the controversies and misconception about food as medicine that need to be addressed? We clearly say that it can be expensive if we're going for premium types of foods. But have you come across any controversies and misconceptions?
I've been called upon to bring up the controversies.
Yeah.
So I actually want to echo back to the research question that Dave was talking about, because that comes up a lot at these food as medicine meetings in conversations like across the US. Some people say the research is clear. We do not need any more research. We're sick of pilots. Let's just do it. We do not need any more research. And other people feel differently, and they feel that there's not enough research. And I think the reason behind that is what my colleague is referring to, with kind of the complexities and social determinants of health that happen behind the scenes. Like food as medicine is so much more broad than just delivering food to certain communities. And especially in New York State right now, our healthcare system has this demonstration waiver that's going on. And so a waiver basically allows the healthcare system to pilot a new project to determine if it's worth it, if it's going to bring a return on investment to the system, as long as it doesn't cost the system more money than it's already spending. And so that just passed in New York State. It's called the 1115 demonstration waiver for Medicaid. And what it would do is it would allow the health system to basically contract with community-based organizations that deliver the wraparound services that we're talking about. So anything related to housing, transportation, food services, food nutrition is a huge part of it. So basically now healthcare is going to start paying for these services. But this gets back to the research issue, because they don't know what the reimbursement rate is going to look like, because how much food is going to guarantee a certain drop in blood pressure or in cholesterol, with all these other variables and factors going on. So with that, this is like an ongoing issue, but I do think about the report that came out of JAMA in 2018. That was a large epidemiological study. It was a meta-analysis, systematic review, and they looked at the relationship between diet quality and deaths in the US adult population. And what they found, not only was food the number one leading cause of death for American adults, but also they found that there were more deaths caused by not eating enough good foods that protect us from disease than eating too much of the bad foods. So more deaths were caused by eating too few fruits and vegetables, anti-inflammatory type foods, which to me is very clear that the mindset, we can't be talking about restricting. We should, to an extent, but also it's like, what more can I add to my plate? Every meal, every bite, we're all human. We all need to eat every day, right? So what more can I add every time I eat? Can I start every meal with vegetables, greens, whatever I can add to just kind of buffer that a little bit? So that was a long-winded answer, but
No,
that's something.
And it's amazing. There's actually a great organization here in Niagara Falls called Grow. I don't know if you guys have heard of it before. It's just down the street on 4th Avenue there. And what it is, it's actually a grocery store for those who can't afford healthy eating. And you get a bag of milk for $1. You can get potatoes for 50 cents a bag and things like that too. So for some of your patients that you're referring to, they can't afford these healthy eats. Their organization is actually created by a doctor out of Alberta. Who came up with this concept, and I had the chance to go visit there. It was fantastic, and like I said, it's a great example of how government and municipalities can subsidize a lot of these food costs to have a healthy population. And the next question is to Dr. Coria, and then Jimmy, can we get the Oscar music ready in case he goes over his 5 minutes? The question is, how cost effective is using food as medicine compared to a traditional pharmaceutical treatments? And with that, by having a public healthcare system, how much is that these pharmaceuticals actually being a burden on our public healthcare system as opposed to prescribing food?
You're setting me up to get myself in trouble. So I'll stay in my. You don't want to open this can of worms and then give me 5 minutes to.
So you suggest can of worms?
Yeah. So can I just make one comment about the research first? Uh, you know,
Mm.
it's really good to have research, but research is designed to be really conducted in a certain way where it is very beneficial for a medication or a pharmaceutical company to test a drug versus placebo or versus another drug and say, this is a randomized controlled study and this is better than this. But how do we test eating this food versus this food? You cannot. You cannot design a proper research. You go and do population studies, and then that's not randomized controlled, studies. So it doesn't have that. It doesn't have that power. Just want to say that. But how affordable is it to eat healthy? I think it's more affordable to eat healthy than unhealthy. It costs more to eat out than to make your own food. It costs more to buy something at the grocery store than to grow it yourself. We just did a big, you know, garden this year. It was our project. Costs us maybe $5-10 in seeds, and I can't tell you. I have so much greens. I'm just trying to give it away to people, and they're like, enough. I haven't had the last batch. I haven't finished the last batch. So it's like it's coming more than we can consume, and there's 5 of us, and my son eats like as much as 4 people. So honestly, I don't think it's that expensive, but yeah, there are some socioeconomic factors that will stop people from being able to start a garden. Maybe they don't have the place to do that. They are not allowed their landlord doesn't allow it, whatever it is, right? But as you guys just mentioned, there's tons of resources out there, and they can reach out and they can get good stuff, and it's a lot cheaper to buy vegetables than it is to buy steak, right? And we don't really need steak in our diet. You need some essential amino acids, which you can get all of them from your eggs in the morning. Okay, and it's not expensive. You grab a couple of chickens. We just have our nurse practitioner. She started a chicken coop and it's expanded, and now she has more eggs than she can have.
In
Right?
fact, Niagara Falls is one of the only municipalities in the region that allows chickens.
Yeah, there you go.
Nice.
It's very true. So move to Niagara Falls. Yeah, I'm in the applications for a couple too, but no, and that's it. I opened it up to everybody to comment on that. I think there's a misconception that eating healthy is expensive.
It's not expensive.
Yeah,
I
obviously-
think it's cheaper.
Well, to buy organics and things like that too. Of course it is, but when we look at legumes as a primary source and a staple, I mean, people should be having legumes almost at every single meal.
Go fishing. We're here. Just go fishing. Go grab some fish.
We got water here. It says she's not fishing this season. No, and that's the question. So, any further comments on the food as medicine before I open up the question to the community here?
I just agree that that's, I think, one of the biggest myths, that it is very expensive to eat in a healthy way. And, for example, I mean, you just make a big pot of lentil and chickpea stew with some spices and some veggies in it. You'll eat it for a week. It probably costs $15 to make. It's not that expensive. And there's places like farmers markets, like I said, the Bulk Barn. You can buy these legumes. You can buy the beans. The veggies even fairly cheap. It's much cheaper than eating at a restaurant. And the pre-packaged stuff that you go to the grocery store that markets itself as healthy. We heard about you say meatless burgers and that kind of thing, or keto protein bars. That's the expensive stuff, and it's not even good for you. So, once you really start doing it, it's no more inconvenient once you get into the habit of it. And I really feel, I mean, it can be more expensive. You can go and buy the most expensive whole food plant-based diet that you can, but you can also do it on a budget as well. And once you get into it, I think you'll find that's pretty true.
And then one thing I've been doing too is that if you go to a grocery store, to the international section, look for the international alternative, because
for some reason, the rest of the world does not allow the ingredients that are allowed in Canadian and American products too. So food basics is great, but I go to the international section and you just find something from Portugal or Japan or whatever the case is, and it's a great alternative. It doesn't have preservatives and color dyes and things like that too.
And spices are dirt cheap.
Yeah, exactly, absolutely. Okay, so that ends the formal panel, but now I'll open up the question to the community. Yes, sir.
This is great. Thank you very much. And as I get old, every year that I get older, I'm becoming more and more conscientious of salt and the 30 different names for sugar that they disguise themselves as. A question around supplements. I've heard your comments about black beans and it's better to eat it in the food. Is there any value, or to what degree is there value to getting some of your vitamins and minerals through supplements?
Actually, there is value. You're talking about getting vitamins and minerals. You also have to be careful about what brand of vitamin you buy, and to research a bit on what a reputable brand is. Make sure that there's no kind of history of any of these things going rancid in your omega-3s or something like that. I'm not going to, cast a general aspersion on all supplements, but when you can get it in the whole food, it is going to be better to get it in whole food. And I'm not sure we understand exactly why, the science behind that. But when we seem to extract these nutrients out of whole foods, they're not as effective in many cases. And I don't know the entire scope of literature on that, but I would advise to do it when you can get it involved.
And one of the biggest is actually vitamin C supplements. Actually, hurt more than they actually effective. So just get that from that place.
Right. If I may add to that, so the whole idea behind getting supplements is to get our micronutrients, right? And in my opinion, you get all our micronutrients from our vegetables and fruits.
I agree.
The only thing we really need, because half the year we are covered, half the year we are in winter, and then we have days like this that we don't get any sun, is vitamin D. And if you're dark skinned like me, you absorb less vitamin D, right? So we all need vitamin D. But other than that, if you are a pure vegetarian, then you may require vitamin B12 if you are deficient in it. But I joke with my patients that, you know what, the amount of money that you're spending on supplements, you can give it to me. They are not needed. You can get it from your fruits and vegetables.
It's much better to get it from your fruits and vegetables.
Just very quickly, it was vitamin B12 and D was what my doctor said I was short of, and that's the only thing I'm taking yourself supplements.
Gentlemen in the back.
I'd like to remind people of what Thomas Edison said in 1903 about the healthcare. He said, "The doctor of the future will give no medicine, while interest in patients and care of the human frame and diet and the cause and prevention of disease." So that was 1903. And we're doing all this research because Grandma said that we needed to eat our fruits and vegetables. Grandma was the research. But the other thing I'd like to find out from anyone that does research out there is what is the density of nutrients in the food over the last 50 years? Has that changed? And if it have changed, then you have to eat more to get the same amount of the nutrient that we anticipated getting 50 years ago. Is that part of the reason why a supplement could help to balance that?
I touched on that. I said the food is grown to be bigger and heavier, but it's lacking nutrients because it's genetically modified to be that way, right?
And then
so then we're not so. And then it's expensive to buy that food also, right? So you have to buy this really expensive food that doesn't pack any nutrients, that weighs a lot, but it's just mainly water. So it is a problem, right? And nutrient density is I think one of our biggest problems in the food industry. I think it's at like a less than 50% of what it was a couple decades ago.
Yeah, I want to add to that too.
Certain microbiome, we didn't talk about that.
Okay.
And then also polyvagal, gut function, decreased performance.
Who's this guy? Come on, take my seat. No. And I just want to mention that too. So one of the research I've been doing is actually eating sprouted fruits and vegetables, like broccoli sprouts. Yeah. The sprouted form of a vegetable is actually the most nutrient dense form that you can get before it grows into, because the nutrients disperse itself, right? If you look at it like broccoli, by the time the broccoli matures into adult, the nutrients are spread amongst the whole broccoli plant. If you eat sprouted broccoli, you get all that nutrients in that sprouted or sprouted seed, if you will. So adopting more sprouted vegetables into your diet can help you pack those nutrients without necessarily, worrying about if you're getting that enough amount. Sorry.
Yeah, I just want to add to what you were saying before. has the nutrient density changed over the last few years? Yes, a lot of our foods, I think I would agree with Dr. Puri, have less nutrient density. They also have a lot of other things added to them that weren't around 50, 100 years ago. So the antibiotics that a lot of, animal products are coming with now is hard to avoid. Pesticides are tough to avoid. Talking about the expense of this, the only thing I really break the bank on, because I eat blueberries every day in the morning with my oatmeal, my turmeric, and my nuts and everything else, but I only break the bank on getting organic blueberries because I think it's been shown that there's a high risk of pesticide exposure if you don't do that. But so it's not just that the density of our nutrients are decreased in some foods, you have to avoid some other harmful added things as well.
Yeah,
Artificial colors is a bad one too. The microbiome is a really interesting avenue of research right now. Are getting more and more aware of the good and bad bacteria that lives in our gut that may be the puppet master of all of our body systems. And when we feed them, and they actually metabolize a lot of what we eat. And when we feed our bacteria plant-based whole foods and grains, they produce things like short-chain fatty acids, which help us in many ways. A lot of what they produce crosses the blood-brain barrier, can help us even psychologically, not just physically. It's a very exciting new area of research, is the whole microbiome thing. And again, we could talk for hours on all these topics, but it's good that someone brought that up today too.
Elizabeth, you were wanting to say something.
Yes, just to reiterate about the reducing nutrition in our food supply. So there's a lot of reasons for that. I just wanted to add agriculture and big food and the use of monocrop farms, conventional industrial farming. It's depleting our soil, overuse of fertilizers. And then in addition to that, climate change, right? So because there's more carbon in the atmosphere, the plants are actually growing at a lot quicker rates, and so they don't have enough time to actually pick up and absorb the nutrients and the nutrition from the soil. So, but we are finding farms, and this is an increasingly popular label or practice, regenerative farming, where it's more of the entire ecosystem, and it's replacing and returning the nutrients back into the soil. So hopefully more of our farms will adopt those practices.
It's funny you mentioned that. We actually have a company that practices regenerative at the hub, where they actually feed their black soldier flies organic food, and then after, when the black soldier fly produces feces, that is then used as a fertilizer back into the soil. So I completely agree with that. And just to mention on the organics, so what good rule to follow is the clean 15 and the dirty dozen. So it's from the Dr. Greger's book. But basically, there's 12. I can't list them all, but there's 15 that you don't need organic, and then there's the dirty dozen. One of the biggest ones is actually grapes. Grapes are probably the highest pesticide foods of all time, and in fact, in the Niagara region, Niagara Lake is one of the highest cancer rates related to the pesticide use on grapes. So make sure you get your organic grapes and try to get organic wine if you can. I had one more question in the middle here.
Yeah, real quick. I just want to talk about like a lot of things about, you look at the past, right? You always look at the past, and back then, I'm thinking about, I'm from Italy, and good story. I see all kinds of older folks, and how are they getting up a hill and up and down? They didn't have research, they didn't have double-blind studies. All they had was kind of good sense. They have an organic food microbiome. They're eating a lot of dirt, right? And they're growing their own food. So don't forget about dirt. And also don't forget about scarcity, because scarcity drove their health, because they didn't eat a lot because they didn't have a lot of cash. We have a lot of disposable income right now. I can go to Starbucks. I get high glucose filled drinks. And I think what's happening today is we have a lot of access to capital, cash. I can go anywhere I want, get anything I want, anytime I want. In Europe and different parts of the world, they had to fight and capture their meals. Maybe 2 weeks later, they had to use that glucose that was sitting in their liver to process. So it's a different day. That's one thing. That's great we brought that up. Number two is the elephant in the room. Why would a pharmaceutical company ever want us to change? Right?
Food is making us sick. Pharmaceutical industry keeps us managing the sick.
Yes, you're in the management business.
Yeah, yes,
the pendulum is this.
Yes, I
you're
am.
managing, and the other pendulum was the food.
I went to school 12 years to do their dirty work. Thank you for reminding me.
I would say, however, that one size does not fit all, right? We have patients who have, okay, I'll give you a personal example. I am a very active guy, very healthy, but I still have high blood pressure. And I did everything that I could do to control my diet, everything possible. I still have high blood pressure, right? I have to take a medication, right? I have to take a medication. I don't want to die of heart disease because we know the risk. So I am 100% when we say that we have to adopt the lifestyle changes, 100% agree with that. But we cannot completely avoid that we would require medication. And in fact, I'm not here to promote medication, but I would say that previously we would have medications like insulin or sulfonylureas, which actually secrete insulin. But now we have medications that are working on the core problem, right? I won't name the name, but everyone knows that. But essentially, so lifestyle is the cornerstone of our health, no questions about it. But there is a still role of medication. And if we are very healthy, we will minimize the use of medication. But if we are not, we would need those medication.
Correct. Yeah, perfect.
I think some of the things that we have to bring it back into the schools. We talk about going to med school and only having 12 hours of learning when it comes to nutrition, but like we were taught how to cook in school and how to sew and how to do all those things, but that's been removed from the school. And I talk to patients and I'm trying to explain to them how, what is a carbohydrate? And Dr. Masood said how, I think it was Dr. Masood who said there's no, our body doesn't know the difference between a cookie and a vegetable when it comes to those carbohydrates, but these people don't even know what a carbohydrate is. Like patients don't even have a clue what a protein is, and this generation is bringing up the next generation and so forth. So we really have to try to bring it back to our kids and our grandchildren and our future. And the importance of our schools teaching this stuff again.
Absolutely.
I'll give you an example of a retired dentist that I saw a few weeks ago. And you would assume the healthcare provider, he knows about things on like 4 different medications, and essentially hemoglobin A1C should be normal in a diabetic, should be below 7. His like running around 8.5 to 9. Right? He was on all the medications. What he did not know about was what he should or should not be eating. And that is the whole
huge
epidemic of problems that we have.
That's why he developed diabetes to begin with.
Yeah, that's true.
Well, that concludes our panel for today. Sorry for keeping you so long. Again, you can follow any of these individuals, amazing individuals, on LinkedIn. I'm sure if you have conversations with us, share their email, have further conversations after this. We want to thank our panelists for joining us today. A lot of them making the trip down from Buffalo and in different parts of the region. So we want to thank all of them. Thank you guys for joining us too. It was a very insightful panel. I'm sorry about the water, like Mayor Diodice says, that's not your fault, right? Water. So thank you so much. Again, yeah, I know. We're gonna forward our panelists, and anybody wants to get forward with these rock stars, by all means.
Thanks, guys.
Yeah. Please,